Welcome to the Future of Dermatology Podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
I'd like to introduce my colleague, Dr. Leandra Barnes, who is an instructor at Stanford Dermatology. At Stanford, she's also the founding director of the Stanford Medicine Skin of Color program, the director of Advocacy, Equity, and Inclusion, and also co-director of the HS Clinic. At Stanford, she, in addition to managing HS patients, she also takes care of patients with other conditions that disproportionately impact patients of color. And Leandra will be talking with us about optimizing the HS Clinic visit.
Let's start with some background information about HS. It's an extremely painful and disfiguring chronic inflammatory disease with an estimated prevalence of 1% in the United States. HS is currently under-recognized, and there is a significant diagnostic delay of 7 to 10 years. We have limited treatment options, and many patients have difficulties obtaining them. HS disproportionately affects women and minorities, particularly African Americans. Combined, this delay in diagnosis, limited treatment options, and disproportionate effects on minorities leads to distrust of the medical community. These factors impact quality of life, and in one study, 15% were reported disabled due to disease. Ultimately, these aforementioned factors suggest that there are many barriers to obtaining care. Recent studies have highlighted these barriers, which include cost, lack of knowledge of HS, and stigma. These barriers are important to understand to optimize patient visits. Just last year, we elucidated barriers to HS care from the lived experiences of people with HS, as shown in the model here. This cyclical model highlights how various factors, including disease activity, employment, healthcare coverage, and costs may influence the ability of people with HS to access patient-centered care for their condition and thereby improve their disease activity. These interviews identified two key aspects of patient-centered care. One, healthcare professional attitudes and knowledge, and two, health system characteristics. Negative provider attitudes and lack of knowledge of HS were identified as barriers to HS care. Specifically, participants had difficulty finding providers who really knew what to do with HS and felt stigmatized by sighs of disgust during physical examinations. They appreciated clear and honest communication, even if the provider shared that they did not know something or they didn't know what the next steps could be, but were willing to partner with them to move forward. Health system characteristics were also highlighted, with participants praising infrastructure that allowed for timely care of disease flares, quick messages for triage, and multidisciplinary care approach to address complex topics like mental health, support, and chronic pain. So as clinicians, we face challenges too. There are issues with diagnosis. How will I know it when I see it? There are also time constraints. I only have 15 minutes to get the history, examine the patient, counsel them, place orders, and write a note. There's also the issue of treatment complexity. Which of the many treatment options do I choose? And last, there's patient complexity. Patients may have comorbidities and psychosocial impacts that I cannot manage on my own. So what can we do as busy clinicians? We can optimize the HS clinic visit by addressing barriers, including knowledge gaps, stigma, comorbid conditions, and access by improving our knowledge of HS and management, being empathic, communicating clearly, communicating clearly, empowering patients to manage disease flares, and enlisting help from specialists in other fields. So believe it or not, we can actually achieve this in our standard 15-minute visit, but it will take preparation and more than one visit. So before we even step foot into the patient room, we must prepare. We have to build knowledge of HS diagnosis, severity assessment, and comorbidity screening and treatment. We review the patient's chart or referral materials beforehand and even consider sending an intake form ahead of time to minimize the time we must spend during a very busy clinic encounter so we can optimize the time spent in the room with the patient actually discussing treatment plan. We'll educate our support staff. Specifically, 1, we'll teach schedulers basic disease assessment to prioritize patients with greater disease burden. And 2, set up patient rooms with chuck pads and extra blankets, and even have extra syringes of ILK on hand, so about 10 to 20 mg per cc, as we'll learn from our experts later, and wound care supplies prepared in advance. We'll also create note templates to streamline the visit. So when considering a patient intake form, you can consider things like disease history, current symptoms, comorbid conditions, and treatment history. Those things will really help to minimize the time that you need to spend in the room getting that information. We can figure out what worked well so we can try it again, or what didn't work well at all. So then you don't have to waste your time in the patient's room trying them. Importantly, other clinical staff can help pre-populate this information into the note so you can quickly review it prior to the visit. And so in this slide, I just have an example of a clinic room setup, because another important consideration is how you set up the clinic room. Remember, as we know, patients with HS are often living in pain and with the stigma of their condition. And so we can show empathy by trying to make our patients more physically comfortable in the exam room, such as providing a pillow to help distribute weight, chucks to absorb possible drainage, and an extra blanket to help cover with. So now you're in the visit. You're prepared, you've reviewed the patient's information beforehand, and you're equipped with knowledge of HS. So your patient is now in the room and you're there with them. What can we do within the visit to optimize it? Ultimately, we can build trust. We listen and show empathy. And remember that nonverbal cues matter. We're gentle and respectful with physical exams, trying to keep the patient covered whenever not examining a particular area, and asking for permission before revealing or touching another area. You can even consider taking photos, but of course with patient consent, in order to track disease severity. Last, expectations are important to establish early on, and they must be clearly communicated. So not everything can or must be done on the first visit, but close follow-up can ensure nothing falls through the cracks. And not every patient with Hurley 1 disease progresses to Hurley 3 disease. And then last, while there is no cure, improvement may be slow and with some setbacks, we do have options for treatment, and I will be with you every step of the way. Next, we'll assess itch, pain, and drainage. We also screen for comorbidities, which can help focus treatment and inform referrals. Note that patients' top priorities are actually related to treatment and flare management, especially during the initial visit. So gauge interest in those treatment options, but also be prepared to treat aggressively, because some patients may want more time to think about it, which is okay. A few days to months being untreated may not matter to some, but it is important to give patients that option to have more aggressive treatment options early on. Early intervention is key to halting disease progression. So this March, as we've discussed, or we will discuss later, is not inevitable. We have therapies that can help prevent this progression and get patient disease under control, but they tend to work a little better the earlier they're started. The length of time that this window of opportunity lasts is variable. It could be 1 month for one patient, could be 5 years for another, and some patients may never progress to tunnels and scarring. So it's important to act soon as you make the diagnosis, just in case your patient is one of the ones that is a little bit more active and could develop into more severe disease that could require procedural intervention in the future. And then in terms of counseling, it's really important for us to dispel common myths about hygiene, the contagious nature, and losing weight to cure HS, among others. We should discuss treatments broadly at the first visit, but we can go into more detail in subsequent visits. It's also important to stagger medications to minimize side effects and improve adherence. As kind of as you guys probably know as well, but as depicted here, if all medications are started at the same time, sometimes patients may have worse side effects because they are stacked on top of one another, such as with GI upset. Or if they have a side effect, they may not know which medication is the one to blame, and then will stop all of their medications. So instead, just focus on an approach with a timed, gradual introduction of each therapy, starting with the fastest acting therapy to get them some relief, such as oral antibiotics in some cases, and then add additional therapies in order of importance. And then at the end of the visit, make sure to coordinate close follow-up every 3 months to start. This will allow you to counsel on topics that you might not even have been able to discuss at the previous visits, and then become more aggressive with treatment as necessary. In addition, providing resources on support groups, such as Hope for HS and HS Heroes, as you can see here, will help enable patients to feel connected and empowered between visits. Last, you can provide an after-visit handout to summarize key points discussed in the visit. This ideal after-visit handout will include some key information presented on 1 to 2 pages and address things like facts and myths about HS, therapies and flare management, lifestyle modifications, and information on patient support groups, as well as the national organizations, such as the HS Foundation. And then last, we can develop a phone and or message triage system to promptly manage flares. These messages can be triaged to 1, needing an in-person visit for urgent intralesional triamcinolone or another procedure, or 2, a virtual visit or photo review to coordinate topical steroids, prednisone, oral antibiotics, or pain medications. For the former, it's helpful to save 1 to 2 hidden 10-minute slots so that patients can be seen within 1 to 2 days for a flare. It may also be helpful to coordinate with colleagues to ensure access on all days of the week, especially if you don't practice every day. These interventions may ultimately keep people out of the emergency room, which we know can be costly both to the patient and to the healthcare system.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.